introducing a break. I didn't want to interrupt the robust academic discussion going on online. But good morning, everyone. It's with a heavy heart I open our last session, our time with Professor Anderson and Ms. Spicer. And this session is dedicated to the function of the univentricular heart. I think we have a video from Professor Anderson to start us off from a developmental perspective, and then we'll move to Ms. Spicer's specimen illustration. With that, we can move to the video. Thank you.
So, ladies and gentlemen, we're going to continue our discussions of cardiac development. By now, I've told you about building blocks, and in the last session, I told you about septation. In this session, I'd like to contemplate the processes of septation relative to the functionally univentricular heart. But before I get into the developmental aspects, I'd like to consider with you one or two semantic points, because I'm sure there are many of you who still think of the univentricular heart as being an anatomical entity. But I hope you'll appreciate that, in fact, it's extremely rare to find hearts that have a truly solitary ventricle. In the past, we had great discussions about what made a univentricular heart. But now we know that the majority of those hearts that 50 or 60 years ago were said to be univentricular or single ventricles, we know that in reality they have one big and one small ventricle. And what I'm going to try to show you now is how our knowledge of development permits us to produce logic into the understanding of the varied lesions that nowadays we know are functionally univentricular. But why did we have problems in the first place? It was because at the time I started in my own career, it was suggested that the majority of those univentricular hearts were in fact single left ventricles. And there are still some of those who would suggest to you that the classical form of the functionally univentricular heart with double inlet left ventricle is indeed a single left ventricle. Well, there is some truth in that, but the controversy arose because of the presence of the second chamber in these hearts. And in fact, it was well recognized that those hearts considered to have single left ventricles did have a second chamber. But the chamber in question was considered to be no more than an infundibulum. But is that justified? Let's consider the arrangement of the ventricular mass in the normal heart. Now, this is the left ventricle. It has an inlet, it has an apical component, it has an outlet. And in the setting of the normal heart, it is indeed a single left ventricle. It is the only left ventricle in the normal heart. But in the normal heart, it coexists with a single right ventricle. And when we look at that right ventricle, it has an infundibulum. But more than that, it has an obvious apical component, and in the normal heart, it also has an inlet. So how does all of this relate to those hearts said to be single left ventricles? So this is the second chamber that we see in those hearts said to have single left ventricles. And the big ventricle in these hearts is indeed a single left ventricle. But as in the normal heart, they are coexisting with a second chamber, said to be the infundibular chamber, and it does indeed have an infundibulum. But it has much more than that, because it has the apical component of what should have been the right ventricle. This is much more than an infundibulum. It is an incomplete right ventricle. So how can we understand this based on our current knowledge of development? Well, I've already shared with you the basic knowledge that permits us to understand the development of these functionally univentricular hearts. But let me recapitulate. Here is the situation we're at the end of the 4th week of development, very early in development, when we have formation of the ventricular loop. And when we look at that ventricular loop, coming to its inlet end is the atrioventricular canal, and taking origin from its distal end is the outflow tract. And so we can make the reconstruction a little bit later, and we can see what has developed from that ventricular loop. So here is the atrioventricular canal, and as we've learned on several times during our first 2 presentations, the atrioventricular canal at this early stage of development during the 5th week is supported exclusively by the developing left ventricle, whereas what will become the right ventricle is supporting the entirety of the outflow tract. So at this early stage, in fact, the heart, the developing heart, has double inlet to the left and double outlet to the right ventricle. At the same stage, the developing right ventricle is incomplete because it lacks its inlet component, but at this early stage, the developing left ventricle, this is a typographical error, I forgot to change right into left, forgive me for that. The developing left ventricle is also incomplete because it lacks its outlet component. The heart itself, however, unequivocally is biventricular because each of the developing ventricles already has its own apical trabecular component. So let's look again at this picture I showed you of a cut through the developing heart at Carnegie stage 13. Where at the beginning of the 5th week of development, I showed you this picture before. This is the right atrium. The cut is replicating the oblique subcostal cut you can produce during your echocardiographic examinations. And we can see how already the right ventricle is developing its own apical component. But it supports the entirety of the outflow tract. So all the blood that is going into this outflow tract, originating from the right atrium, going into the left atrium and the left ventricle, has to come through the embryonic interventricular communication because the right ventricle lacks its own inlet. And this is exactly what we see in this congenital malformation that you will know as tricuspid atresia. So in tricuspid atresia, we know the right ventricle is incomplete. It has an apical part, it has an outlet part, but just as in the developing heart at the early stage of development, it lacks its own inlet portion. And when we take a 4-chamber cut through a heart with tricuspid atresia, concentrating on the atrioventricular junctions, we know that in almost all examples of tricuspid atresia, the atresia is due to absence of the right atrioventricular connection. In fact, when I started my career, it was often thought that the tricuspid valve was imperforate in this setting. We now know that very rarely you can have imperforate tricuspid valves with concordant atrioventricular connections, but this is the exception rather than the rule. And almost always, tricuspid atresia, as you see here, is the consequence of absence of the right atrioventricular connection, such that it is only the left atrium from the atrial component of the heart that has a connection to the ventricular mass, specifically to the dominant left ventricle. So how can we explain that? Well, here is another cut from the human embryo at Carnegie stage 13. And what we are looking at here is the primary septum. In the last session, I showed you how the primary septum grows from the atrial roof towards the atrioventricular cushions so as to divide the right from the left atrium. But what happens if instead of growing midway in between the atrioventricular cushions, it is malaligned and and grows to the right side of the atrioventricular junction. That is going to give us tricuspid atresia, committing the left atrium exclusively into the ventricular mass and meaning the left ventricle is going to be the dominant ventricle. So let's look at that again in a 4-chamber cut through the heart at this early stage of development. There is the primary atrial septum. If it grows in such a way to fuse with the right margin of the atrioventricular junction, then the left atrium will be committed to the dominant left ventricle. The right ventricle will be incomplete. And that is what we see, as I showed you a moment ago, in tricuspid atresia. But what happens if the atrial septum grows as we expect it to, so as to divide the atrioventricular junction into right and left junctions, but without any expansion of the atrioventricular canal? That is going to give us double inlet left ventricle. And lo and behold, when we have double inlet left ventricle with concordant ventricular arterial connections, the right ventricle as its apical component, an infundibulum to the pulmonary trunk, and this, of course, is the Holmes part. But what happens if the primary septum grows in such a way as to wall off the left atrium from the atrioventricular junction? Then we will have absent left atrioventricular connection, still with a dominant left ventricle. Almost always, this is found with left-handed ventricular topology, because the ventricular loop goes the wrong way round, but very rarely this can also be found, as I show you here, with right-handed topology, the incomplete right ventricle to the right of the dominant left ventricle. So we can explain all of the variants in the setting of dominant left ventricle, depending on the way the atrial septum, the primary atrial septum, grows relative to the atrioventricular canal. But we've already said that if development proceeds normally, there is rightward expansion of the atrioventricular canal. If that expansion is incomplete, we have straddling tricuspid valve. But if the expansion is exaggerated, then not only can the right atrioventricular junction be committed to the right ventricle, but so can the left atrioventricular junction. And that will give us not double inlet left, but double inlet right ventricle. And in that setting, the left ventricle will be incomplete and hypoplastic. So let's look at this process of expansion of the atrioventricular canal. This is what happens when it is incomplete. There is malalignment of the ventricular septum with straddling and overriding of the tricuspid valve, here with the tricuspid valve mostly to the left ventricle. But this is the consequence of exaggerated displacement of the atrioventricular junction into the right ventricle, such that both of the junctions are committed to the big ventricle, which now has right ventricular apical trabeculations. And when we turn the heart round, there is our second chamber. It is an incomplete left ventricle this time, but with straddling of a papillary muscle, confirming there has been exaggerated displacement of the atrioventricular canal into the right ventricle. But not all functionally univentricular hearts have complete and incomplete ventricles. You will all be aware that the majority of patients who come now for conversion to the Fontan circulation have hypoplastic left heart syndrome. Others have pulmonary atresia with intact ventricular septum. And the key to the understanding of these lesions is the integrity of the ventricular septum, because they are acquired diseases of fetal life. The very fact that the ventricular septum is intact tells you they could not have come about until after there has been closure of the tertiary embryonic interventricular communication. So when we look at hyperplastic left heart syndrome, we know we are looking at a spectrum of maldevelopment. At the worst end, we have combined mitral and aortic atresia. Then we can have mitral stenosis with aortic atresia. As things get a little bit better, but still bad, we can have combined mitral and aortic stenosis. And at the best end, we can have the so-called hyperplastic left heart complex. But in most of these, in the presence of mitral stenosis, we find fibroelastosis in the left ventricle. Now, there is one point about development, because when we first described and encountered these lesions, we thought the mitral atresia represented absence of the left atrioventricular connection. We now know that is not possible, because during normal development, at some time, the atrioventricular canal has been in communication with the developing left ventricle. So when we look at specimens that have hyperplastic left heart syndrome, and I'm sure Diane is going to demonstrate specimens like this to you, here we see the combination of a stenotic but patent mitral valve with aortic atresia, and its flow in and out through that stenotic mitral valve that gives us the thick-walled fibroelastotic lining in the hypertrophy but hypoplastic left ventricle. But when we look at the combination of aortic atresia and mitral atresia, there has been no flow into this tiny left ventricle. But we now know the mitral atresia is not in fact absent connection, because when we look very carefully, we look at the slit-like ventricle, which doesn't have fibroelastosis. There's been no flow into it or out of it, but we can see the track that initially connected the two during embryonic life, with this change reflecting changes occurring during fetal life. And it's a similar story with pulmonary atresia with intact ventricular septum. But here it is mural hypertrophy that squeezes out the ventricular cavity. So again, we have a spectrum of disease, and it's only those at the worst end of this spectrum that are functionally univentricular. And here you see a nice example, because the mural hypertrophy has obliterated the apex. You can see a track leading towards the pulmonary trunk, but it also has been obliterated, so that although the heart itself, the right ventricle, has its three components, in essence, the cavity is only the inlet. We have a tripartite ventricle, but with a unipartite cavity. So what can we say about the function of the univentricular heart? Almost always it is anatomically biventricular. Most of those that you see in the clinics that are going to be converted to the Fontan circulation are acquired diseases of fetal life. It is only the minority that have univentricular atrioventricular connections, but hopefully, as I've shown you, we can now offer a plausible explanation in terms of development for all these various lesions.
Dr. Anderson, I think that was best for last. That was really great. So my impression of what you're putting forward is one should not use the term hypoplastic left heart syndrome in the presence of a ventricular septal defect. Would you maintain that is similarly true for a remote muscular VSD? Would you still say then therefore that term should not be used?
I think if it's a remote, tiny muscular VSD, then you're justified in thinking of them as hyperplastic left heart syndrome, just as you are if you have a tiny perimembranous defect. You do have cases where the ventricular septal defect is so small as to produce the same situation as when the ventricular septum is intact. But I do think that the essential integrity of the ventricular septum should be part and parcel of what we call the syndrome, recognizing, of course, that the left ventricle can be hypoplastic in the setting of a ventricular septal defect, but as you imply when bringing in the notion of the muscular defect, usually when you have a perimembranous defect of substantial size, the morphology of the hypoplastic left ventricle is totally different from what you see in the syndrome.
Thank you. Questions from the room? Chat here. Chat. Very well. I think we can move on to the specimen illustration. Thank you.
Just on what we needed to bring to this meeting, the number of parts we are going to talk mostly today about hypoplastic left heart and pulmonary atresia. But I was able to bring a few hearts that fit in with some of the other groups. Talk a little bit outside of those other two entities. So when Professor Anderson talked about tricuspid atresia, the so-called classical type of tricuspid atresia, he mentioned that there's no potential for a connection between the right atrium and the right ventricle. And we saw this heart yesterday when we, do you need to put that here? Put right here. And we saw that yesterday when we talked about, or actually we saw it on Tuesday when we talked about vestibular atrial septal defects. And this heart does have pulmonary atresia intact septum, but it also has a hypoplastic right ventricle and an imperforate tricuspid valve. So here on both halves of the specimen, you can see that there's a diaphragm of tissue blocking egress of blood from the right atrium to the right ventricle. And because this tricuspid valve over time became very stenotic, the right ventricle ended up with hypertrophy of the apical trabecular component, and then eventually the valve became imperforate. At autopsy, this was a very beautiful specimen because there was all dark red blood clot in this cavity. And I have those initial pictures, but it was just a really nice representation how that blood got trapped in the right ventricle after that valve became imperforate. The point we need to make is that you can see there is a potential for a connection between the right atrium and the right ventricle if this ventricle was large enough. And you can see that the atrial myocardium is in continuity or meets the ventricular myocardium. Whereas when you have the classical type of tricuspid valve atresia, that is not the case. And we have a case that we looked at yesterday with common arterial trunk. And you can see that I can lift the right atrial mass directly off of the roof of the right ventricle. So the right coronary artery will run deep in this atrioventricular groove, but there's no potential for a connection between this right atrium, which is dilated and hypertrophied, and the right ventricle. A lot of times you'll see a dimple at the base of the right atrium, and I think I have a straight pin here attached to this towel somewhere. And so in most cases, if you put that pin in that dimple, it ends up over the left ventricular cavity. You can see it there. So that this just tells us that there was failure of the right atrioventricular junction to expand. And there is an apical trabecular component. And in this case, there was a common arterial trunk, but it was supported by a complete muscular infundibulum. And the VSD is actually juxta-arterial in this case. More often than not, the VSDs are towards the inlet or the apex in a classical type of tricuspid valve atresia. Then I have that heart that had the uniatrial but biventricular connection, so that it does have quite a good size right ventricle, but the four-chamber view shows nicely the very large right atrioventricular groove between where you can lift the right atrial mass off of the right ventricle. You can see the right coronary artery running deep within that fiber fatty tissue, and that there is no potential for a connection between the right atrium and the right ventricle. So just a nice four-chamber example of what tricuspid valve atresia looks like on a four-chamber echocardiographic view. But as we discussed the other day, our right ventricle is of good size here, as is the left ventricle, because of this straddling mitral valve. So not a univentricular heart, but a uniatrial but biventricular connection, but showing the anatomy really nicely on four-chamber view. And Professor Anderson also talked about extensive expansion of the right atrioventricular canal. And we can tell that this heart was a cardiac explant. You see the big right atrium, morphologically right atrium here in our tricuspid valve. And when we look at the left side, here's our appendage. It's finger-like, and it's actually folded backwards rather than being over the anterior lateral aspect of the heart and towards the pulmonary trunk. You can see that the left atrial vestibule is small, as is the mitral valve orifice. I'd like to point out to you that the crest of the ventricular septum is actually right here, because this portion of the mitral valve actually, just like the imperforate tricuspid valve I showed you, fused down to the septum, and there is an imperforate component right here. So when we look at this right ventricle, it is the larger of the two ventricles, and you can see that there is a tricuspid valve and a mitral valve, both extending into this dominant right ventricle. So this is actually a double inlet and a double outlet from the right ventricle. You can see the aorta here and the pulmonary valve here, both supported by complete muscular infundibulums. And so when we talk about, I don't have any double inlet left ventricles, but when we talk about double inlet left ventricle, the rudimentary ventricles typically here on the anterior superior aspect of the heart or on the shoulder of the heart. And when we have this situation with double inlet or extreme straddling of the mitral valve, this tiny left ventricle is on the posterior inferior aspect of the heart or in the hip pocket of the heart. So this tiny ventricle here, you can see right next to my probe, there's a little bit of left ventricular endocardium. Difficult to hold open, but here's where the valve is adherent to the crest of the septum, and the apical component of this ventricle is pretty much obliterated. So just a nice example of a double inlet right ventricle with a hypoplastic and rudimentary left ventricular chamber. But as Professor Anderson stated, there is one large ventricle and one small ventricle, so a functionally univentricular heart. There are some other cases that fall into functionally univentricular heart and have a double inlet right ventricle as well. So this actually was another explanted heart, and I have it cut in four-chamber plane. The coronary arteries are not really all that specific in this specimen, but we will see that better when we look at the hypoplastic right and hypoplastic left hearts. But you can see nicely that there was an unbalanced atrioventricular septal defect, and the valvar, the bridging leaflets were adherent to one another across the crest of the septum. The inferior aspect of the valve was nearly imperforate, and there was a small area where there was blood extending into this hypoplastic left ventricle on this aspect, the associated with the superior bridging leaflet. So you can see that the majority of the blood was entering this right ventricle, so pretty close to a double inlet right ventricle with a common atrioventricular junction with separate left and right orifices and a hypoplastic right or left ventricle with a solitary papillary muscle. So this is the crest of the interventricular septum. So these hearts with dominant or right ventricular dominance to the atrioventricular junction can also fall into this group of double inlet right ventricle. But again, that hypoplastic and rudimentary chamber is in the hip pocket of the heart or posteriorly located. I do have some hearts that show a total imperforate component of the left side of the common atrioventricular valve. And we saw this heart when we looked at atrioventricular septal defects, and it as well has an unbalanced situation where there is right dominance of the common atrioventricular junction. The left ventricular cavity is extremely small, so you can see the scooped out portion of the septum here, and this is the left component of this common atrioventricular valve. There was also an inferior muscular ventricular septal defect in this specimen, and it went to have a Norwood procedure. So you can see they've done an atrial septectomy here, and you can see the leading edge of the atrial septum. When we look at the tiny left ventricle, there is hardly any cavity here. You can see the tendinous cords attached to the scooped out portion of the septum, and there was virtually no papillary muscles supporting that common AV valve within this tiny left ventricle. The aortic outflow tract actually was fairly patent. There was a unicommissural arrangement with, it was a trisinute valve, but with a unicommissural arrangement with only one complete interleaflet triangle. You can see there's an incomplete one there and another one over here, so that this patient went to have a Norwood procedure. Here is what was the common pulmonary trunk. You can see the duct was ligated. Here's the left PA and the right PA, and the pulmonary circulation was supplied by a modified Blalock-Thomas Thomas shunt. When we look into the aorta, the neo-aorta, I should say, there is the DKS where they connected that hypoplastic aortic valve to the pulmonary trunk or the neo-aorta, and you can see the arch was hypoplastic, so that they filleted it open and sewed it in to a portion of the pulmonary trunk and augmented with a patch all the way around the arch. So you can see the brachiocephalic vessels branching from the arch, and there is where the ascending neo-aorta was augmented with a patch. So this is the same procedure that we see in hypoplastic left heart, and as well with those cases like this one that has an unbalanced atrioventricular septal defect. I do have a hypoplastic left heart with a Sano shunt to show you as well. So I guess since we ended with hypoplastic left ventricle, I will show you the spectrum that I have here, which can be quite variable as far as the size of the left ventricle and the different phenotypes, as Professor Anderson stated. So this little heart went to transplant, and you can see if I flip it over, the coronaries will delineate the ventricles because they follow the septum. So nicely here you can see that it's outlining this small left ventricle. It's of fairly good size, but it doesn't yet meet the apex. When we look into the mitral valve, it's thickened, adherent in some areas directly to the tips of the papillary muscles, and with very thickened tendinous cords. The left ventricle is small, but there is quite significant endocardial fibroelastosis. And when we look at the aortic valve, there is that commissural unicuspid appearance. So the only interleaflet triangle is here between the left and the non-coronary leaflets, and that is typically the only interleaflet triangle that remains intact in these specimens. You can see the raphe here between the non and the right coronary valvar sinus and leaflet, and here between the two coronary valvar sinuses. So these valves actually have much more of an annular appearance than do a regular valve that has the semilunar appearance. So this little specimen has proportionate hypoplasia of all of the components. And this is the heart that is now falling into what some people are calling hypoplastic left heart complex. So all of the structures are proportionately small, and some institutions will try and grow these left ventricles to see if these patients can end up with a biventricular circulation. Most of the hearts I have are cardiac explants that we see these days. I get them on the surgical bench, and not many go to autopsy. So here, again, is an explant. A lot of times, the tricuspid valve in these specimens has some degree of dysplasia. Here, this one even has a small component of an Epstein malformation, so a micro Epstein malformation. The right ventricle is often hypertrophied with extremely thick trabeculations, and there is the pulmonary outflow tract. Very often don't get much of the atriums. Aside from the right atrium, we typically get a lot of the appendage because it's typically dilated. The left appendage typically does not make it to pathology, and we just end up with this little remnant of the atrial vestibule in hypoplastic left hearts. So here you can see the mitral valve is opening is actually quite tiny. And here on the outside, you can see the coronary arteries following the septum. And when I see extremely dilated coronaries, that's indicative of coronary to left ventricular fistulas. And I have a few cases that I can show you with that arrangement. But here you can see this tiny mitral valve, extremely stenotic, and the tendinous cords are attached to a solitary papillary muscle, and then there's this little muscle bar that's crossing between the free wall and the septal surface. So essentially a parachute mitral valve. Shows up a bit better looking from this side. So you can see all of those tendinous cords attaching to that solitary hypoplastic papillary muscle, and there's that little chordal attachment extending to the free wall. The aortic outlet is patent. So this is mitral stenosis, mitral atresia. The ventricles are usually a little bigger than this in this case, but just to point out that there is quite a bit of variation. And here again, the valve is unicuspid, unicommissural, and a bit thickened, but still aortic stenosis. Yeah, I think it's next.
Oh, fantastic.
So many of these hypoplasts I will cut in a 4-chamber plane because sometimes in pathology we end up destroying the posterior aspect of the heart in search of the left ventricle. And one of the very last specimens I'll show you, you'll be able to see why. So here is another explant. Nicely, you can see the coronaries outlining this tiny left ventricle on the posterior aspect of the heart. Here is its apex. It does not reach the apex of the heart. And when we look at it in 4-chamber plane, this shows very nicely how the right ventricle almost wraps itself around the apex of the left ventricle. And you can see this very thickened globular mass surrounding this left ventricular cavity. And this is a consistent feature. Again, you can see this quite dysplastic tricuspid valve in this case. The way this specimen was cut, most of the tricuspid valve was left on the inferior aspect, and most of the mitral valve left on the posterior aspect, or the inferior aspect. So when we look at this mitral valve, it shows really nicely that all the tendinous cords are fused directly to the tips of the papillary muscles, and this is what an arcade malformation looks like. So my probe is in the orifice, so whoever made this lucky cut left most of the mitral valve intact so that we can see what this looks like. But again, you can see that extensive endocardial fibroelastosis within this globular left ventricle. And this specimen has mitral stenosis, as we can see. But if we look at the anterior aspect of this specimen, so from the spine towards the sternum, and I turn the aorta up, or the base of the heart up, you can see the big pulmonary trunk, and here is the aortic root. So it's not as tiny as I've seen when you have aortic atresia, and that's because in this case, the aortic valve is imperforate. So there is a little bit of a dome of valve tissue in here, and it probably was perforate at some point. And if I were to open it down, I could probably bet $100 that it would look like a unicuspid unicommissural valve with only one interleaflet triangle being of good size. But this is aortic atresia and mitral stenosis. So you can have atresia with an imperforate valve, and in addition with a fibrous atretic area, which I think we'll be able to see.
We can pause there. There's some conversations going on in the chat. For the benefit of the fellows, I'll summarize the conversation. One of the questions was, can we label the ventricle as the double inlet when there's a single common AV valve? Professor Anderson responded, the inlets are dependent on the junctions. If both junctions are committed to the same ventricle, then there is a double inlet. The junctions can be guarded by separate valves or a common valve, but it is the commitment of the junctions, not the morphology, that defines double inlet. It's a great question there. And now there's some interest in coronary fistulas, Diane. So one question is, do you assess for coronary fistulas in an MSAA heart? And building on that question, would you tell us about the formations of sinusoids to the right and left ventricles? Do they have anything to do with the compaction of the myocardium and myocardial perfusion in early development?
Well, I know that Professor Anderson always says that they should be called fistulas and not sinusoids, because they are true fistulas. There are sinusoids within the ventricles. but they usually are very tiny. I don't know, Professor Anderson, if it has anything to do with so-called non-compaction. I know that the coronary artery development is still being assessed in the developmental stages. So I don't know if you have anything additional to say about that.
I'm typing a response.
Oh. Yeah.
Absolutely.
Hi. For valves that start as perforate and then become imperforate, is there typically a time point in development where that reliably happens, or is it very variable patient to patient?
I missed that question, but can you repeat the question?
For valves that start out as perforate and then later on become imperforate, is there typically a reliable time point in development where that change happens?
Good question. I think the best people to answer that are the fetal cardiologists. I mean, the problem with we as morphologists is we only get to see the hearts once. Diane is seeing increasing number of fetal hearts, but even with the fetal heart, she only gets to see them at the stage where the damage has been done. So, but Diane, do you get any indication of staging as to when the valves become imperforate? Can you put a time point where you might see a perforate valve as opposed to an imperforate valve?
Yeah, I have a number of hearts that have imperforate valves very early, 12 weeks, that look very much like some of these that I'm showing you now. So I think it's probably a random time frame depending on what the flow is going through that ventricle that allows the valve to just say, okay, I'm done, and stick together. Because I've seen imperforate mitral valves in DORV with a hypoplastic left ventricle and an intact septum. I have seen hypoplastic left hearts with when the coronary, we use the coronaries in these fetal cases to assess the size of the ventricles because they're pretty reliable to let us know if we have one small and one big ventricle. And the perinatal pathologist I work with, if I'm not there, she's doing the specimens, she will stop because she says something looks not right and leaves it. And one of those cases was an imperforate mitral valve. And so we just ended up cutting the heart in 4-chamber planes. So I have a really nice few collection of photographs that show in those teeny tiny fingertip size hearts that have imperforate valves. So I think it's probably just dependent on the flow in those particular patients at that because you see all these here that have progressed to newborn that have, you know, half decent sized valves like that tricuspid valve atresia in the PAIBS. So I kind of agree with Professor Anderson. We can't really tell. If people can watch it over time on echo, I know I have one case that was progressing to hypoplastic left heart because it had critical aortic stenosis. They followed that baby and emergently delivered them on the day they saw on echo that the aortic valve became imperforate because it was perforate all the way along. And that ventricle nearly reached the apex. It was very hypoplastic, but even dilated. So as it was getting rid of its dilation because of the aortic stenosis, once they saw that aortic valve close on echo with, you know, serial, like every couple of days they were following. At 31 weeks, they delivered the baby, but it didn't survive. So I have that history to go on that you can follow these things fetally. So I think it's just probably patient-related and defect-related.
You You mentioned the pathologist you work with is pausing to let you bisect the heart. I've been wondering all week long, what's your kind of secret sauce in terms of how you can transect these valves so perfectly with what looks to be a single cut? I struggle to bisect an apple, but you're bisecting the apple and all the seeds inside it. How do you do that?
Practice. And initially, when you start to cut things in echo plane, you have to just do it, knowing by the anatomy you know from the outside of the heart. I have had a couple of people instruct me in the past to do like a long axis echocardiographic cut. I have instructions actually in the Handbook of Pediatric Autopsy Pathology where you can put pins at certain points and you run your blade relative to those pins, and it usually comes out pretty good. But a 4-chamber cut in hypoplastic left heart is actually pretty easy because the coronaries are outlining the septum, and you can see clearly the valves where they're at on an explant. You don't have the atrial component. So explants are easy to cut in echo plane. And I know Professor Anderson, I have seen him just take a knife and just do it, and he is perfect every time. But for me, it's taken some practice to get to this point. Did he answer the coronary question?
I tried to. I think that, I mean, we know that early in development, the coronary arteries are in continuity with the spaces between the trabeculations and the wall. And it's only later in development when the coronary arteries achieve their communication with the aorta that you start to get hypertrophy and hyperplasia of the compact layer of the wall. So I think it's fair to say that in the hypoplastic left heart syndrome, the fistulous communications you see are a retention of the embryonic situation where the spaces within the trabeculations were in continuity with the coronary arteries. But in most of the instances, when you have the fistulous communications, they're microscopic. I mean, you've got some examples with overt ones, have you not, Diane?
Yeah,
but they are.
I do.
So why don't you? It's best if you show them, I think.
Yep. That was the next 2 hearts that were up when that question came. So this specimen, looking at it from the short axis, we can see the aorta is here and the pulmonary trunk is here. And in these hearts that have aortic atresia, you can see there's a blind ending aortic root here. The ascending aorta pretty much functions as a conduit for the coronary circulation. And I have a really nice intact autopsy heart where I can show you how that circulation progresses. But this is a nice short axis showing us the right coronary artery and how it is extending in the right atrioventricular groove. And here you can see it becomes very ectatic, dilated or bulbous, if you will, here towards the inferior interventricular space. I took a chunk of it out here that we'll look at in a minute. And here you can see there's this very bulbous coronary, which is in the position of the anterior interventricular artery. And when we follow it back, you can see that there is an atretic segment of the left coronary here, where all of the flow was being pushed through the coronaries retrograde rather than antegrade. And so this guy just decided to shut down. If you're not giving me any flow, I'm not going to work. So everything was coming retrograde rather than antegrade. And sometimes you can end up with proximal coronary artery atresia. So here you can see that there were multiple large coronaries communicating between the right coronary from this infundibular branch over to the anterior interventricular branch. And when we look at this from the left ventricular aspect, you can see how large, this is a 2 millimeter probe, you can see how large that fistula was. And I have taken a chunk out of this ventricle just to show the size of some of these fistulas. So there is part of that coronary, but on this free wall, you can see from the coronary into the ventricle how large that fistulous tract was. And I couldn't get across all of these others, but you can see where they were progressing through the myocardium to the coronaries, here again towards the apex. And you'll note that this case has mitral stenosis, and we already looked that there was a blind ending aorta. So that mitral stenosis, aortic atresia, these are the cases that typically we see these fistulous coronary to left ventricular connections. But you'll note that there is not a whole lot of endocardial fibrinoelastosis in this hypoplastic left ventricle, because there wasn't a lot of turbulence, because everything was going back out of the coronaries. So just a really nice case of very large coronary artery fistulas in hypoplastic left heart with mitral stenosis, aortic atresia. This next case is quite interesting. Again, I've cut it in 4-chamber plane, very globular heart. Looking at the coronaries on the outside, you can see there's a whole number of tortuous ectatic coronary arteries. Here, even inferiorly, hypertrophied right atrium. As I mentioned, we get quite a bit of the appendage on these cases, and here is our tiny aorta, which was atretic. You can see the coronaries coming from the aorta. When I cut this in 4-chamber plane, this is another one of those hearts that shows us nicely how the right ventricle kind of holds the left ventricular muscle in the palm of its hand, and the right ventricle curls around it and forms the apex of the heart. And this heart was particularly interesting, mitral stenosis, and probably had an arcade-like malformation of the mitral valve. It's not as easy to see in this heart, but extreme endocardial fibrinoelastosis. And distal to the endocardial fibrinoelastosis, you can see that there was probably more of this left ventricle at some point in time, and it just got obliterated by mural hypertrophy. And it shows nicely on this opposite aspect, again, hypoplastic mitral valve, extensive endocardial fibrinoelastosis, but you can see nicely all of this trabecular component that was distal to the endocardial fibrinoelastosis. I decided to cut this in another slice because I thought that there were coronary to left ventricular fistulas, and you can see here the endocardial fibrinoelastosis and some of those trabeculations that were being obliterated, but you can also appreciate that there was a coronary to left ventricular fistula, this bulbous ectatic area on the epicardial surface. So just a really nice example to show how the cavity can increasingly get smaller and smaller because the trabeculations at the apex are being obliterated by mural hypertrophy. So this is a heart that did come to autopsy following a repair of hypoplastic left heart. So you can see there's quite a long sano shunt, and I have seen them both to the right and to the left of the arterial pedicle or the neo aorta. When we open the right ventricle, they did an atrial septectomy to allow flow across from the right to the left atrium, and vice versa. There's the tricuspid valve. The right ventricle was quite hypertrophied, and it's kind of difficult to show, but you can see where the Sano shunt was plugged in to the free wall of the right ventricle. It extended up, attached to the pulmonary trunk, and then you can see the right and the left pulmonary arteries bifurcating from that, and there was the arterial duct ligation site. Very often at autopsy in older patients, I will get them with stents in these pulmonary arteries because they become stenotic. This patient did at one point have a Blalock-Taussig Thomas shunt that you can see was taken down. This is the brachiocephalic trunk, and that's where they clipped it off to do the Sano. Pulmonary or the neo-aorta is not opened into the right ventricle because of the Sano. See if I can get a good view of the DKS here. So this small hole right here where my probe is going is what will feed the coronary arteries. And that is what was the ascending aorta, this very tiny little filleted open structure. You can see the sutures on either side of it, and then where they've sewn the aortic arch in to the neo aorta. This is patch material to augment the ascending component of the neo aorta, and the valve would have been the old pulmonary valve right here. 1 leaflet, 2 leaflets.
Off the heart. Is that what it usually looks like?
No, this one to me looks
It's
way too big.
Oh my God, it's striking. It looks like a handle.
Yeah, I mean, yeah, I agree. When I did this case, I was like, wow, is this getting anything through that big long trek? It does look big, and you can see that there is a segment, there's a segment, and there's a segment. So all 3 of these segments have been sewn together. And like I said, I've seen them to the right and to the left of the arterial pedicle. And I don't know if this one is so long because they went to the right of the arterial pedicle. I can't really answer that question. Too bad our surgeon isn't here today.
No, I'm here, but I'm just trying to cross security as we speak at the airport. I think I'll keep my phone closed.
I don't remember the history on this. I do so many autopsies. But this specimen, actually, I cut the left ventricle in a 4-chamber plane because I noted as I opened the left atrium that the mitral valve was imperforate. And you can see that the left ventricle is still filled with blood clot. There is a diaphragm of valve tissue up here at the top. You can see it as well here. So this was a left ventricle that's more slit-like than globular because of the mitral atresia and the aortic atresia. You can see it's not as muscle-bound, and there is no endocardial fibrinoelastosis. So this mitral valve must have became imperforate fairly early on, so that this baby did not develop much EFE in that left ventricle. But you saw how big that left ventricle was. We saw this case the other day when we talked about our coronary sinus interatrial communications. And this patient was actually, I was waiting on a transplant and was on a ventricular assist device. The heart is quite large and quite hypertrophied with a small amount of tricuspid valve dysplasia. This case had aortic atresia, mitral atresia. You can see how tiny this ascending aorta is. There was a stent at the isthmus, the transverse arch to the isthmus, and you can see that the left subclavian was coming off immediately across from the opening of the arterial duct. And sometimes you can have that coarctation. You can see it's actually impeding a little bit on this left subclavian, and I have a really nice case to show you in a minute. So this case did go to autopsy. The patient did not receive a heart prior to coming to autopsy. This case had, as we saw the other day, an imperforate mitral valve represented by this little valve nubbin here. Actually, I think I just put a hole in it. So that valve was kind of prolapsing into the left ventricle. So it was imperforate. And this little ventricle, you can see I've made a couple cuts looking for it. So then I just removed the roof of it, and you can see it's filled with blood clot. It was a very tiny ventricle, as opposed to that last ventricle who was a bit more elongated with imperforate mitral valve. But you can appreciate that this imperforate mitral valve was about 4 or 5 times smaller than the surface area of that last imperforate mitral valve. So you can just see from the questions we've already talked about that there's quite a bit of variation in all of these structures on the left side of the heart, and it probably follows just a patient-to-patient situation as far as where the preferential flow is going and how much flow and all those variables. So this was a case that came to autopsy via the emergency room because this baby went home as a normal baby. And when things started to not flow correctly, you can see there's a giant arterial duct here, and the atrial septum was wide open. So there was some availability of shunting here, and we were all ready to do a metabolic autopsy on this baby, which is quite time consuming, I will tell you. We have to freeze things, we have to take multiple fluid samples. So we were all set up to do all of this work because this baby came to the ER crashing. And as soon as I opened the chest, all of that preparation, I said, we don't have to do it because I saw this tiny aorta and I knew exactly what the diagnosis was. So you can see this tiny aorta, which tells me that there was probably aortic atresia, and this case did have mitral atresia, aortic atresia in this left atrium. There was a dimple at the floor of the atrium where there would have most likely have been a connection at some point. You can see the circumflex coronary running in this atrioventricular groove. There's the coronary sinus. And you can see this typical appearance when you have mitral atresia, aortic atresia of this slit-like elongated ventricle. It kind of has the shape of a normal left ventricle, just tiny, not so globular. And there is no endocardial fibroelastosis. This is pale, but it's not endocardial fibroelastosis. And here again, you can see how nicely the coronaries outline this tiny ventricle that does not reach the apex. So this is one of the nicer specimens to show you how the flow of blood go around in these patients. Actually, this patient had distal origin of the right subclavian as well. So there was right carotid, left subclavian. The aorta acts as a conduit for the coronaries. So the blood will come in from the systemic venous component, and some will go across to the left ventricle through the ASD, but the majority of the blood is going to go through the right ventricle, out the pulmonary trunk, out this big duct, and down the descending aorta. But some is going to feed retrograde and go up the brachiocephalic vessels to the brain, because it is the most important part of the developing fetus and infant. And then whatever's left will go down the ascending aorta to the coronaries. So you can see immediately where the preferential flow goes. And then this gets small because no flow, no grow, but it just gets that little bit to supply the coronaries. When we look at the arch, you can see coarctations associated with these cases. This one has a small ridge that is actually juxtaductal. It comes right in the middle of where the arterial duct is joining the isthmus and the descending aorta. Different color of the intima of the duct as opposed to the intima of the aorta. And actually the pale color that extends up around this small ridge or juxtaductal coarctation. And actually some of this pale tissue here may even represent ductal tissue. And I have sectioned these areas in the past, and microscopically they show up as ductal tissue. So sometimes I see these stripes of pale tissue, and now that I've sectioned a few of them, I kind of assume that this is a bit of ductal tissue. So it doesn't always maintain itself within the duct or directly related to coarctations or the isthmus or the immediate descending aorta, but you can see stripes of tissue extending in the aorta.
So for that case, for cause of death, just because the ductus still looks pretty large, what?
And the foramen was open too.
Yeah. Okay, so still not.
I'm not sure why the baby crashed, but like I said, it came to the ER in severe distress. Was there any evidence? Yeah, there was some areas that were, you can see this subendocardial. Yeah, so that's a good point, because you can see this subendocardial hemorrhage or discoloration actually in this area here too. This is subepicardial. So these areas are the farthest away from the coronary circulation. So that could have been, just some ischemia and failure that way. So that's a good point. I hadn't thought about that, but. So this was another case that was undiagnosed in utero, but this one I think happened way back in the 1995, I believe, when I was at Tampa General. So again, you can see this tiny, tiny aorta. And when we look at the arch, this I brought to show you because the coarctations can cause quite a bit of havoc with the brachiocephalic arteries, depending on where they arise. So this one has a fairly good sized duct as well, but you can see a fairly tight constriction here adjacent to the isthmus and where the left subclavian arises from the arch. So it's causing severe stenosis, slit-like opening of that left subclavian because of where the coarctation is extending, and very hypoplastic ascending aorta. And this left ventricle was quite hard to find. There was mitral atresia, aortic atresia, and this case also had a persistent left superior caval vein. You can see it draining to the coronary sinus. And so I went looking for the left ventricle. They are quite hard to find, and I don't think we specifically found one on this case. I kind of sliced off a piece of myocardium there in hopes to find it.
Looks convincing to me.
So in the right atrium, you can see this very dilated coronary sinus because of that persistent left superior cable vein. And this, we had a conversation the other day about the atrial septum. I know somebody asked a question about the atrial septum, and this is one of those cases where you can see the flat valve is pushed way towards the left atrium. You have to kind of reach in there to find the edge of it. And when you look at it in the left atrium, you can see the attachment. Oops, sorry. Let me look at the screen here. So here is the flat valve. You can see how redundant it is. Here's the opening for the appendage. And you can see that it is pushed way into the left atrial vestibule. So some of these flat valves are deviated much more to the left than others.
Earlier in a session I might have missed, but did you guys talk about, again, the reason for kind of the thickness of the atrial septum and
Right atrium or left atrium?
sorry, the atrial septum? Like,
Oh,
a
the
lot of times
atrial septum.
Yeah, why it's so
Well,
much thicker. And
when you think about it, if the atrial septum is restrictive, the mitral valve is stenotic and the aorta is aortic, the left atrium is kind of pumping against a lot of resistance, and it's going to thicken to begin with. And some of these cases will have pulmonary lymphangiectasia. They'll have muscle extending up into the pulmonary vein a lot more than is normal. Yeah, so this, I have two hearts that look exactly like this. And here you can see, again, it's an explant. This is the right atrium. There's some endocardial fibrolastosis in the right atrium here as well. And here is what I was left of the left atrial appendage and the left atrial vestibule. So here's our aortic root. You can see the coronary arteries coming from it. It almost looks like the main branch of both of these coronaries. And there's our pulmonary trunk. And I cut this heart in a 4-chamber plane, and it shows a couple of features pretty nicely. I would have never found this left ventricle if I went looking in the myocardium just by slicing in this way, because you can see how slit-like it was. So that's what's left of the left ventricle. And I cut into this again, and you can see here, that's where the left ventricle was. And what shows nicely on this specimen is what Professor Anderson pointed out as far as development, as far as knowing that there probably was a connection at some point. Because remember all the normal heart dissections that I've talked about, where there is fibrous continuity between the tricuspid valve and the mitral valve. And you can kind of see that, some of that in this area here, so that this is the floor of the left atrium. And you can see that little fibrous tract right there. When we get even, well, that's the aorta. But even when I cut even more, you can still see that fibrous tract right here between the left atrial floor and the right atrial floor. Not so sure if it shows up so well on this side. Yeah, here's the left atrial floor. And you can see how there's that fibrous continuity between the left atrial floor and the tricuspid valve, telling us that there most likely was a mitral valve at some point. But you can see how slit-like that left ventricle is. You can kind of follow it all the way down. So cutting some of these things in four-chamber view is fortunate for me to identify the small nature of the left ventricular chamber. But this shows nicely how there was at some point a mitral valve, because we still have this tricuspid to mitral valve fibrous continuity. That will do it for hypoplastic left heart.
Question in the chat from Dr. Mololiteron. Is the atrial muscular buttress bigger and dominant in some HLHS cases? Wonder if that's why the primary septum gets smaller and pushed upward, hence the waterfall ASD on echo.
It's a good question. I'm not sure we've looked at that. Very
Well,
good question.
And I'm just looking at some of these explants to see if I can recognize the muscular buttress, because we're not usually left. I think it's here, this little muscle here, muscular buttress, and I don't think we have noted that in all the hypoplastic left heart things that we've looked at.
It's a very good point. It's
I
something
think
that
this is buttress here, and you can see where the tricuspid and mitral valve were fibrous continuity right there. But yeah, I haven't noticed that.
certainly the deviation of the primary septum has been well recognized. That was one of the things that the late Paul Weinberg emphasized in the setting of hypoplastic left heart. But I don't think we've placed much emphasis on the buttress. It's a very good point. Something we need, something to look at.
When you two go out and prove it after this, I'm sure Ashok would be happy to be a co-author on that paper.
Yeah, so here in this heart that wasn't a transplant, you can see the buttress here. Then within the left atrial side, this would be the buttress.
Yep.
That's the coronary sinus interatrial communication. So, no, like you said, we haven't looked at that specifically.
We've only recently appreciated the significance of the buttress as the true second atrial septum. So all of these things give us more to think about as we move on.
Okay, so we're going to move on to talk about pulmonary atresia intact septum. This specimen is quite large, and there was pulmonary atresia, but the right ventricle has all three of its components. The flap valve was probe patent. The tricuspid valve was a bit stenotic compared to the right ventricle, mildly dysplastic, and large apical trabecular component, but the right ventricle was quite hypertrophied, and there was pulmonary atresia. So the outlet component is fairly well formed, aside from the muscular atresia at the extreme root of the pulmonary trunk. So it looks as though there may have been at one point an imperforate pulmonary valve here, but it is now atretic. When we look at the Coronaries, there is quite a dilated coronary in this particular case. I can go all the way down to the middle of the anterior interventricular, but I'm not sure that there were any fistulous communications. Yeah, there may have been one here, but quite a large heart with pulmonary atresia, intact septum. You can see the left ventricle was intact. There is some subaortic hypertrophy in the septum, and both coronary orifices are quite large. So you can have, in most cases, when I see a ventricle like this, it exists with pulmonary stenosis, intact septum. The apical trabecular component we will see becomes increasingly hypertrophied in these cases. This was a case we looked at when we were talking about tricuspid valve dysplasia. It was pulmonary stenosis with intact septum. You can see that the right ventricle does not reach the apex, and it's kind of a bifid apex in this case. There was an augmentation of the right ventricular outflow tract. You can see that there was at one point an aorta to pulmonary shunt that they've clamped off, and may have been the reason for this main pulmonary artery to become a bit bigger. The duct has been ligated, and there are the branched pulmonary arteries. When we look at the atrial septum, this one had a partially divided atrial septum. There's the oval fossa, which the flap valve was deficient, so there's an atrial septal defect. And this tricuspid valve was quite dysplastic with a sort of windsock structure that was protruding up towards the pulmonary outflow tract. So probably one reason for the pulmonary stenosis. The myocardium or the apical trabecular component is not that obliterated, but there is right ventricular hypertrophy. So this is a tripartite right ventricle. They've removed the pulmonary valve, and they augmented the right ventricular outflow tract as it was initially stenotic. They palliated this patient with this aorta to pulmonary shunt prior to this attempt at repair and getting this patient to a two ventricle situation. The left ventricle was markedly hypertrophied, and there was mild dysplasia of the mitral valve, actually with some of those little curtain-like extensions that we saw in the tricuspid valve. This case was palliated with a Blalock-Taussig Thomas shunt, a modified shunt from the brachiocephalic trunk to the right pulmonary artery. At the arterial trunks as they exit the ventricular mass, the pulmonary trunk has been ligated here, and you can see the distal component here. Left pulmonary artery and the right pulmonary artery connected to the Blalock-Taussig Thomas shunt. When we look at the inside, there was a surgically created atrial septal defect, and the right ventricular tricuspid valve was quite dysplastic. The leaflets are adherent directly to the papillary muscles. There are fused tendinous cords. You can see that the tricuspid valve leaflet has virtually no tendinous cords, and you can see, though, that it did delaminate up to the hinge point, so would not qualify for an Epstein's malformation, but just very short tendinous cords. The inlet component is hypoplastic. the apical trabecular component is being obliterated by mural hypertrophy, and you can see a fairly well-formed outlet. So we would call this a bipartite cavity within this tripartite right ventricle. And when we look up at it's difficult to show because they've ligated the pulmonary trunk, but there was an imperforate pulmonary valve. You can see just at that white structure adjacent to my forceps tip, that was the imperforate valve. So pulmonary atresia, intact septum. We can see that the ventricular septum was intact in this case, and the left ventricle does form the apex. When I first looked at this specimen, which was a cardiac explant, it's kind of flattened, and that's because sometimes we get these specimens put into containers that are way too small for them, and they get fixed in a distorted fashion. But here on short axis, you can see the dilated, hypertrophied remnant of the right atrial appendage. The mouth of the coronary sinus is here. So sometimes we get these intact. This coronary sinus looks quite large, so I could speculate that there may have been a persistent left superior caval vein just because of the size of the coronary artery. A section was removed here for histology, and I will tell you that in most places that I work, I try to tell people that you don't need to take a section in all of these specimens because the diagnosis is actually the congenital malformation. So there's no need to disrupt the anatomy. We do typically take one section of our explanted hearts, but I try and make sure I do it in an area that's not going to disrupt the anatomy. So here you can see the tricuspid valve was very stenotic, not so thickened, but extremely stenotic. The right ventricle is of good size. There is some mural hypertrophy at the apex, but we can still recognize an apical trabecular component. The right ventricle almost reaches the apex of the heart. And when I looked at this heart initially, I was like, oh, nice outflow tract. Actually, that is a large fistula. So you can see how large that fistula is. And on first examination, it actually fooled me. I thought it was the subpulmonary area. But here is the actual outflow tract to this right ventricle. So somewhat of an outflow tract, but with muscular atresia. And when we look for the pulmonary trunk, here it is. And you can see it's basically just a thread coming from the ventricular mass. And this area here was most likely fed retrogradely by an arterial duct. You can see there's just a pinpoint lumen at that portion that remained patent, but a very thread-like structure. And here you can see this very dilated left coronary orifice where that large fistula was being fed retrograde from the right ventricle back up to the aorta. So one of the largest fistulas I have ever seen in a heart with pulmonary atresia, intact septum. Let's see if we can see the right coronary. There. I probably need to do a bit more dissection. The right coronary actually looks kind of tiny. So just a very large fistulous tract. Sometimes we do get a bit of atrial septum remaining on these cardiac explants. You can see from the short axis how tiny that tricuspid valve orifice was. So this is right atrium, tricuspid valve, mitral valve, and we were left with quite a bit of the left appendage here. So very often you can assess atrial arrangement on these explants just by looking at what's left of the appendages and what's left of the pectinate muscles. Here you can see the mouth of the coronary sinus where it was coming into the right atrium. And we were left, in this case, with a little bit of the flat valve and quite a bit of the atrial buttress. And as I looked at this, I saw that there was a vestibular atrial septal defect.
Beautiful.
And when you look at it from the left side, you can see it goes along with the anatomy I talked about earlier on Tuesday, that it is actually closer to the mitral valve hinge point than it is to the tricuspid valve hinge point, secondary to the normal offsetting of the atrioventricular valves. So I've cut the free wall of this right ventricle away. You can see that the tricuspid valve was extremely stenotic. There is a component of an Epstein malformation here. So this portion failed to delaminate just a bit, and it's very stenotic, not quite so thickened, but very stenotic. So we have almost total obliteration of the apical trabecular component here, and you can see this very skinny little outflow tract extending up to where we have pulmonary atresia. And the way I tried to cut this was to show that this has tri-radiating sinuses at the base of the pulmonary trunk. You can kind of see that little Mercedes-Benz sign in there. 1 sinus, 2 sinus, 3 sinus. And so there was muscular atresia at the very distal end of the subpulmonary outflow tract and tri-radiating sinuses within the base of the valve. So we only have 2 small components remaining in this very hypertrophied right ventricle. And there were no actual grossly identified coronary artery to right ventricular fistulas in this particular case. Another explant with pulmonary atresia intact septum, and this one shows the coronary artery architecture on the epicardial surface quite nicely. The pulmonary trunk in this specimen was not even identifiable. Of course, it was an explant, so something may have been cut at the base of the ventricular mass, but usually they don't mess around too much in this area. But this shows really nicely how you can get dilated and stenotic, even to atretic components along the length of the coronaries, depending on where the retrograde and the antegrade flow are hitting one another. So this segment here is a bit stenotic, as well as the left main being stenotic. The right coronary is here and also becomes quite dilated and ectatic as it extends towards the inferior aspect. And so I've cut this in a 4-chamber plane, and this specimen did have tricuspid valve stenosis with an Epstein malformation. So you can see here the septal leaflet is plastered to the wall, the septal surface of the right ventricle, and actually the septum has become quite thin. You can see it's even dilating a bit towards the left ventricle. And here is one of those fistulous tracts you can see nicely coming right in to the right ventricle. The apical trabecular component was pretty much obliterated. And up in here, you can see another hole and yet another hole where these are communicating with this very large ectatic anterior interventricular branch. The opposite side, where the inferior aspect of this heart we can see has, again, a dilated or thinning septum, and there is the rest of the septal leaflet that is plastered to the septal surface. And you guys see this nicely on echo when you don't see that septal leaflet moving. So an Epstein's malformation in association with pulmonary atresia intact septum. And you can see here where another fistulous tract was coming in. So lots of variation in this group with coronary arteries, size of the ventricles.
What would you have called that very dilated fistulous connection? You wouldn't call that a left anterior descending because it's in a really odd
I wouldn't call it a
orientation.
what?
A left anterior descending. It's in a odd orientation. What would you
It's
still
in
call
the,
it that?
It's in the location of the anterior interventricular, because if you follow it, here's the septum. So it's actually following the septum. So the coronaries will mark the ventricles because they follow the septum. And you can see here with the inferior interventricular artery coming. So I would call this the anterior interventricular. This is the circumflex here. This is the left main coronary. And so they don't always, when they have these giant fistulas that dive into the muscle, they don't always epicardially delineate the septum. But if you follow this, where it would communicate with the right ventricle, it is actually running right towards the septum. So I would call that the anterior interventricular. It just is not showing up on the epicardial surface as well as it normally does because of the fistulous tracts. This is a more recent explant that we had, and we put this case, they did a CT on this case, and we put it in our surgical theater, and we were able to see the fistulous tracts very nicely and see how large they were. When we look at this case on short axis, you can see the extensive hypertrophy of the right atrial appendage and the right atrium with endocardial fibroelastosis. So a lot of turbulence in this atrium. Here you can see some of the coronary sinus in the atrioventricular groove. Most of the roof of it has been cut away. This is the atrial buttress and the mitral valve vestibule and the mitral valve. Here is the aorta. Yes. And it's because of turbulence. It produces like a scarring on the endocardium. And so when we put this into surgical theater, they were actually looking for the coronary arteries to see what the anatomy was. And you can see here, Patrick, this is a nice one to show in addition to that last heart that I was telling you about, where the coronary dove into the muscle right here. But this one doesn't actually dive all the way into the muscle. There are fistulous communications, but you can see it nicely outlines that hypoplastic right ventricle. It doesn't reach the apex, very far away, in fact, but it is in the same position as that last coronary we looked at, but on the epicardial surface. It also shows us a dilated takeoff from the aorta and an area where it's stenotic here, and it becomes more ectatic where there are fistulous tracts. The interest in this heart was looking for the right coronary artery. And so we could follow it on within the atrioventricular groove, and we could follow it to this structure here that actually, with imaging, we were able to follow this, and then we lost it. We couldn't see it anymore. So the pulmonary trunk, in this case, So it's very tiny and fibrous. So we thought that when Dr. Q was in there doing the transplant, that he would look for this and tell us where it went, because it obviously becomes atretic. Well, you can appreciate it's a little brown on the edge, which is cautery artifact. So he really didn't he really didn't give us the answer, and didn't see where this was going. So this was most likely an atretic right coronary artery, but we're not sure if it ever joined the aorta or if it joined a collateral or something, or a vasovasorum vessel, which I have seen one case of that, and that, like I said, is the tiny pulmonary trunk. So we weren't able to get our answer, but on imaging, we see the exact same thing as we see on the gross specimen. We just lost it right over the anterior aorta. When we look at the right ventricle, you see the tiny tricuspid valve with some fused cords, obliteration of the apical trabecular component. And the outlet component becomes very tiny with muscular obliteration towards the distal subpulmonary outflow tract. And the fistulous tracts were actually quite nice. You can see one coming right here. There were multiple going towards the apex, down to these ectatic coronaries at the apical component, and then there were some that were coming off of here. And we could show them all on imaging by cutting into the myocardium, way better than I can show them here, so that we could see the tracks running to these ectatic portions of the coronaries. And you can see that big hole right there. We could demonstrate that very nicely on imaging to show that there actually was a channel between that hole and the coronary. So imaging has been really a lot of fun for me to learn about these specimens before I even get them. And you can see that the left ventricle was quite hypertrophied, maybe even a little bit of increased trabeculation at the apex, but widely patent aorta. We could not find a right coronary orifice. There is the left, and there was just this kind of little ridge or divot next to the commissure here, but no real vessel on the outside that I could see that went to that area. So we weren't really sure where the right coronary started, but we could see that there was some in the right atrioventricular groove, and it took us right to this little atretic structure. This is yet another PAIVS. The atrial septum was much intact. It was probe patent. This was an autopsy specimen in the late fetal period. So there's the tricuspid valve, very thickened right atrium. I put the free wall back on. See that there are a number of bulbous ectatic coronaries at the right, extending from the right atrioventricular groove. The fistulous tracts can be seen here. Another nice one here to the anterior interventricular. The interesting thing that there is no tri-radiating sinuses at the base of the pulmonary trunk, just a blind ending pulmonary trunk. There's the right coronary, quite dilated in the right atrioventricular groove. And again, we have pretty much just a unipartite cavity, obliteration of the apical trabecular component and of the pulmonary outflow tract. So you can see how these things just progress. Very large hepatic coronary arteries. And one of the other interesting things that we can see associated with pulmonary atresia intact septum is sometimes we get these very curly arterial ducts. You can see this one looks almost like a corkscrew. So these are stentable. They do stent them, and that's another reason that we put these cases in our surgical theater to look at the duct so that the interventionalists know what they have coming. So just an interesting thing that with PAIVS, you can sometimes see these corkscrew or curly arterial ducts. So this last specimen I have is similar to one we saw the other day. We were talking about tricuspid valve and Epstein malformation. This case, you can see the very tiny right atrioventricular junction, much larger mitral valve and left atrium. There's our appendage. We look from the front of the specimen. The pulmonary trunk is just this thin little thread here. See the right coronary coming. Actually, here is the right coronary. The left coronary but anyhow, there are no fistulous tracts on this, within this specimen. And when we look at the inlet, you can see that it was totally obliterated by a severe Epstein malformation. So there's the valve basically blocked off the inlet and the outlet. So there is the only apical trabecular component that we see here. This is atrialization of the right ventricular wall. It's like a very transparent, dilated little pouch, but there is no discernible tricuspid valve leaflets because it failed to delaminate. So an Epstein malformation, and there is virtually no outlet. So just this little bit of apical trabecular component with a very severe Epstein malformation and atrialization of this inferior component of the right ventricle. The left ventricle is, again, very dilated and hypertrophied. I'm not sure if that's EFE or not, or just some fixation of the back. So I don't, Professor Anderson, what would you call this? Just a unipartite cavity, because there's only a little bit of the apical trabecular component?
It's a fascinating heart. I think it's unguarded tricuspid orifice, isn't it, rather than Epstein malformation?
Well, yeah, I guess that probably is a better thought now that I think about it.
And is the cavity continuous with the infundibulum, or is there a barrier between the sort of there's a suggestion of the anterosuperior leaflet, isn't there? A little ridge there as you on the underside of the supraventricular crest. An amazing case. That's fantastic.
Yeah, I guess the only reason I didn't think of an unguarded right atrioventricular junction is because the cases that I have seen, the right ventricle has been just like a dilated, thin-walled balloon with pulmonary atresia.
You're right that it has many of the features of Epstein because of the atrialization of the inlet component. But I think that in large part is because there is a unguarded orifice. It's a fascinating case. Never seen anything like that before. You've got a lovely series of pulmonary atresia cases. They were spectacular.
And yeah. So we can see the atrial component here because you can see the pectinate muscles and the
See the right coronary artery there.
yeah, that's what I was just looking for. The fiber fatty tissue at the atrioventricular junction and this little structure that's not showing us a lumen, but it's quite flattened. That is the right coronary in the atrioventricular groove. So you can see where the hinge point of the tricuspid valve should have been, right here at the atrioventricular groove. And this is essentially atrialized ventricular wall.
So it's almost, I mean, that's what happens in OOL, where you have no myocardialization of the wall, but that's the inferior part that's fibrous rather than muscularized.
Yeah, so there is some muscle here on the free wall of the right ventricle that I'm lifting up, and this goes towards the outlet. So
An amazing case.
I would also think that here, this is right ventricle.
Yeah.
Because you can see atrioventricular junction. In fact, that's probably the other side of the coronary here that I'm trying to grab here. So you can see where the hinge line of the tricuspid valve should have been. Because this is the anterior free wall of the right ventricle.
So it's in OOL's anomaly, the valves were normal in the case described by OOL. And
Correct.
this is akin to OOL's case, but there's no formation of the tricuspid valve, and the pulmonary valve is atretic.
Yes.
Fascinating case. Fascinating. So there's no myocardialization of the parietal wall of the right, well, very little myocardialization of the parietal wall of the right ventricle.
Just here.
Yeah. Fascinating
And
case.
I do have a couple of cases that have divided right atrium that are associated with pulmonary atresia intact septum, one of which is a 20-week fetus that I didn't bring because it's getting a bit worn because of the maceration. It was an intrauterine fetal death, but it has huge coronary fistulas, unipartite ventricular cavity, and a divided right atrium. So these cases can show so much variability in the whole spectrum, from pulmonary stenosis, intact septum, all the way up to pulmonary. So that's all that I have to show you guys. Are there any other questions or chats?
Nothing new in the chat. Anybody in the room?
I have a question that is more pertaining to what we talked about yesterday in the heterotaxia or isomerism section. You talked a little bit about interrupted inferior caval veins and azygous continuation, and made one side comment that you purposefully didn't talk about hemiazygous. I guess, am I mistaken in thinking that an azygous vein is a right-sided structure and a hemiazygous is a left-sided structure, at least in abdominal situs solidus? Or what was there anything more to that comment that you made?
If you have mirror image derangement,
Your azygous would be on the left.
right? So Is it a hemiazygous or is it an azygous because you have mirror image arrangement?
It's an interesting point because azygous means unpaired. And in the normal situation, since we have a hemiazygous, we have a half unpaired situation. But I think I agree with Diane. I think it's easier just to call them azygous veins because the point you make, if you find it on the left in left isomerism, it's going to be a morphologically left structure anyway. And in some instances, there are some cases where you have paired azygos veins. I think in the Uemura series, we saw some with paired azygos veins. So have you seen that, Diane?
I have seen them, and I don't know if you remember the little case I had with total anomalous systemic venous drainage that I sent you, where the superior cable vein on the right did not connect to the right atrium. It drained to the left-sided coronary sinus. There were paired azygous veins, and if I ever have opportunity to talk to you guys about the development of the venous system, this heart just shows you how many things can go wrong. Because I had two azygous veins at the very superior aspect behind the trachea and esophagus. I had a veno-venous bridge. I had a normal inferior cable vein. So at the level of the diaphragm between the two azygous veins, I had a veno-venous bridge. The right azygous vein and the inferior cable vein, I had a veno-venous bridge. And then between the left azygous vein and the right azygous vein, very low where the sacrocardinal veins develop, there was another veno-venous bridge. And this dissection took forever. But because I recognized what I had at the top, I just progressed towards the inferior aspect. And I have amazing pictures because I had to separate the organs, but I still have the heart that shows all of the venous abnormalities in the heart. So it was just an amazing case to show what can go wrong. It was systemic. Excuse me, total anomalous systemic venous return. So it was just a really cool case. And I mean, I think the heart is this big, like a $50 size. So it was a 28-week. So I have been trained to take my time with all of these things and to recognize things before I even start my dissection. So just so interesting now to tie how you can tie everything back to what Professor Anderson has done developmentally, certain things.
I have a question, and I apologize for missing much of the single ventricle section. It was a session today. I was doing an MRI, my loss. Is it possible to have a levoatrial cardinal vein and a left SVC, or are those embryologically the same structure?
They are different, and they let me find the heart I had.
Oh, okay. You guys already talked about that.
Well, no, I have a heart that has a persistent left superior cable vein. So the position, and actually, I could run over to the other room. I have a heart that has a so-called levoatrial cardinal vein. So here you see the left atrium, the left atrial appendage, and here is the left pulmonary artery. So the position of a persistent left superior cable vein typically crosses where the left pulmonary artery bifurcates from the pulmonary trunk, and it crosses over where the left atrium joins, or the left atrial appendage joins the left atrium. So when you have a so-called levoatrial cardinal vein, it occurs over here. So in that situation, the pulmonary veins are still draining to the left atrium, but because of mitral atresia, they need a pop-off valve. So they will connect to that levoatrial cardinal vein over here towards the root of the lung and then drain to the brachiocephalic vein. But they're typically closer to the hilar aspect of the lung than is a persistent left superior cable vein. I mean, I have a PowerPoint with the two pictures side by side, and you can clearly see the different positions.
And as
And
Diane, the other point,
sorry, go ahead.
I was going to say, the point is that the vein in question is neither levo, atrial, nor cardinal. So it's one of the situations where we give it a name that means absolutely nothing.
Yeah, because the the persistent left superior cable vein is actually retention of the cardinal system.
Exactly. So the so-called levo atrial cardinal vein is in fact a pulmonary venous collateral channel, and it can drain all over the place. As Diane says, the connections of these anomalous veins can go anywhere, and a lot of them are collateral channels.
Thank you. I have one more quick question that would help me out of a dilemma that I have whenever I report MRIs in congenitally corrected transposition patients, and I try to some verbal gymnastics to describe that the coronary arteries are as expected, with a bifurcating system off the right coronary, which morphologically is more akin to a left system. How do you describe that?
Well, it's the morphologically left coronary artery, as you say, and you're talking, of course, of congenitally corrected transposition with usual atrial arrangement. If you had congenitally corrected transposition with mirror imaged atrial arrangement, then the artery you're talking about would be where you expect it to be, in left-sided position. So I think it's best to call it the morphologically left coronary artery, which then divides into the circumflex and the anterior interventricular arteries.
And I think that's one thing I failed to mention when I talked about the coronaries, is that the coronaries also, like the tricuspid and the mitral valves, go with their ventricles.
Absolutely.
Any more questions? This is your last chance. We don't have those two experts on speed dial, even though I know we all would like to. But
some people do have me on.
Yeah, well, maybe that's something we should entertain. You know, as Dr. Evers mentioned at the beginning, it is with a heavy heart that we have to wrap up our anatomy session of this week. You know, I think I speak for the entire team to call this nothing short of amazing and so valuable for us. You know, I just want to remind everybody how fortunate we were to have those two world leaders really in anatomy that get invited all over the world, World Congress, etc., just all to ourselves for the last 2.5 days. I also want to shout out how well, in my opinion, this worked to have them tag team and have, you know, Professor Anderson's lectures on embryology, and then followed up by the you know, specimens. I want to point out that, especially for Diane, this has been a tour de force. I don't think any other way of doing this than giving her a break, at least during those lectures, would have even worked. And even with that, I think we've really worked her to the bone. So thank you, both of you, so much for being so generous with your time, for accommodating all of our questions, no matter how far out there they were, with grace and lots of information. And just a big hand of applause for both of you.
Lars, can I also make a comment before I depart?
I'm sorry, Bob, that was drowned in the applause.
Yeah, can I make a comment before you all depart? Because I would like to recapitulate what you've just said about the contributions made by Diane. I mean, I've sat here and I've watched her demonstrating those hearts, and really she's become a true master in demonstrating what's going. And the way now she dissects the hearts, she is surely taking everything that I've done into a new dimension. And we mentioned we've known each other since 1982. It's a long time now. She was starting off in Pittsburgh when we first met. I've spent quite a lot of time with her in Florida. We've had some great times together, but she is truly now blossoming into the world expert. Everything that I do now depends on what she sends me. Her photographs, her dissections are without par anywhere else. So you've been very fortunate to have Diane with you for the last 2.5 days. She's done a magnificent job, and we need to persuade her to keep on going because she is now the way forward. And what she is doing now, and the correlation she's making with clinical imaging, as she says, now with clinical imaging, you can see all these things, but you need to know what you're looking for. So we're moving in the right direction, Lars, and it's great to give us the opportunity to present in the clinical setting. And it's great to hear you acknowledging the value of what we're trying to do. So thank you for that. But particular thanks to Diane. She's been spectacular.
Well, nothing left for me to do rather other than letting those words stand by themselves. Thank you again. Thank you for everybody who's participated here. Thanks for everybody who's joined us online. And with that, we'll wrap it up. Thank you.
And thank you, Bob, for those comments. Much appreciated. We've
You
been
did
tag
have-
teaming. We've been tag teaming for a long time.
Indeed. I hope you now have time to enjoy the Oregon Pinot Noirs.
We will.
Cheers.
Cheers. Thank you.